Good afternoon. I'm Michele Courton Brown, and I'm delighted to welcome you to Quality Interactions live discussion. Our topic today is equity in health in virtual healthcare, and I'm joined by my colleague and friend, Dr. Joseph Betancourt, who is the Chief Health Equity Officer at Mass General Hospital's or Partners Hospital, as we call it. What's the official title? Because I know the name has
Mass
changed.
General, yeah, we're now Mass General Brigham. It's the system, and we keep our name as Mass General, so that's a good thing.
Perfect. Who's also the co-founder of Quality Interactions and also the founding director of the Disparity Solutions Center. The last time we talked about a month ago, we were talking about the wave of COVID and where we are today. And I know that every day and week just brings new wrinkles. And I'm wondering if you could just give us a sense of where we are locally and nationally.
Yeah, sure. Welcome, everyone. And thanks for joining us today as part of our conversation. We're excited. Obviously, this has been a very interesting week and still is. And so, clearly we hope, we'll get some clarity as to our national direction soon. And, it's good to revisit where we are with COVID. And I'll maybe highlight a couple of different things. I'd say first, on the national picture, clearly, I think everyone's aware that the number of individuals testing positive continues to go up. And I'll talk about here in our local environment in Massachusetts, we've seen that as well. I think that there are differences for why the number of individuals who are testing positive is going up in different regions. And I just want to make clear that testing identifies cases. So yes, we are doing more testing, but ultimately, when we think about what we're trying to do as a nation and shutting down the pandemic, identifying cases is critical, and there are real cases that we are identifying. So working blindly would not and is not, I think, an effective strategy. But what we see here, I'd say locally, is that we've done a very good job in Massachusetts of being very thoughtful and very progressive around our mask wearing, around social distancing, all the things we've talked about. However, we have moved into and advanced our phases of reopening. And as a result, we do have more essential workers, again, where are exposed. It becomes a numbers game, and the same issues that led to spread previously, all the things we've talked about, multi-generational housing, densely populated areas, and being an essential worker, as we open up, that gets reactivated to some degree. And so we have seen a slow and steady climb here locally. And so I'd say that's been our local story. I would say nationally, clearly in different parts of our country, the rise has been in part due to people's attitudes related to mask wearing. I think that's been a big driver of that. So there's variation, I guess, Michele, I'd say, in kind of why we see the increase, but there's no doubt that we're seeing an increase in test positivity. Now, a couple of other quick things I'd mention. Here locally, we are seeing a larger amount of our test positivity among individuals 0 to 18 and 18 to 39. And so it's a younger demographic. And so to date, those individuals, as we know from before, they are at risk of getting sick, but they're at a lower risk of being hospitalized. Not to say they're not going to be, but they're at a lower risk of being hospitalized. And so even though here locally our numbers have increased, our hospitalizations and admissions to the ICU have slowly upticked, but it hasn't been, I think, similar to our first surge. So I guess that's the second point I make, is that for locally, that demographic is one which we see an increase, but we see less of an uptick in our hospitalizations. We are worried as we think about the holidays and social gatherings and general fatigue with following these guidelines, that these individuals will come in contact with older family members and such that will put them at risk. So we're trying to do a lot around communicating that issue. And I think nationally, again, there is variability in some parts of the country. If we look at the Texas border, if we look at Utah, if we look at Wisconsin, we are seeing very significant increases in hospitalizations to the point where I think crisis standards of care, something we've talked about, are being invoked, I believe, and discussed in Utah. and at the border of Texas, in the area of El Paso, I think Wisconsin as well. The hospitals are very stressed. So like has been the case for this pandemic, there's a variation in stories, but usually some basic themes. And that's what we've seen so far. And again, our big caution to everyone is as we go into the colder months, as people are indoors more, we ask people to continue to remain vigilant, and particularly with the holidays and the desire to gather with family and friends, we can't let our guard down. So I think that's where we are now, and there is a sense that, for example, here locally in Massachusetts, we are preparing and gearing up for this next peak, but clearly there are many places across the country that are, never stop peaking.
Yeah. So let's go back to the first surge, because in the midst of that surge, you, like many other physicians, had to pivot to virtual care really almost overnight. I was wondering if you could talk about, there's been many conversations on the patient side about what that experience is like, but I'd be really intrigued to hear how you experienced it as a physician.
Yeah, it was very interesting, and I know we've talked about it in different degrees, and I'm happy we get a chance to really double down on that conversation today. So a couple things. There has always been this push uh, around virtual health that predated the COVID pandemic, but it had never been fully activated. By that I mean we did have certain innovators and disruptors who were, I think, engaging in the use of telehealth, telemedicine, and by telehealth particularly, I mean virtual, and especially I mean by connecting like we are face to face. And I think that was seen as almost a gold standard, and where innovators and disruptors were going with virtual health. And as you mentioned, when the pandemic hit, we shut everything down across the country, and certainly here, we had to almost immediately try to figure out how to fire up what was kind of a thought, a vision, and quite frankly had been used among individuals who were well resourced, I would say in the concierge medicine space, if you will. I think there was some kind of deployment of virtual health through some early adopters around urgent care, but it was very, very slow, and the penetration was very minimal, I'd say. And the pandemic hits, we have to shut everything down, and we need to figure out how we're going to communicate with our patients, and virtual health becomes that vehicle. Now, I think for me as a caregiver, my patient panel is about 70% minority, about 55 to 60% Spanish speaking. My payer mix is quite diverse because I take care of a lot of our employees and their families who are insured through us. But I think what I began to experience is that many people began to link payer mix. Like if you have commercial insurance, you should be able to dock into virtual health very easily. They're kind of as a marker for connectivity, and that was not the case certainly among my patient population. Many of my individuals lived in hotspots, lived in vulnerable communities, and for a whole host of reasons were unable to connect with me. And so we needed to kind of use the least common denominator of communication, which was the telephone. So what are the benefits of telephone? I get to speak to you, I get to see how you're doing, I get to check in. I don't have any lab information. I can't really see you if I need to kind of get a chance to check a rash, or have you point the camera at your legs to make sure you don't have any edema. So even my physical exam skills are completely taken from me. And that ended up being the experience of many, many vulnerable populations. And I'd say a couple of other things. The way we connected people to virtual health was primarily through our electronic health record. So if you were on our, for example, patient portal or patient gateway, you were then more easily able to dock in and create a visit. We were able to communicate with you. Like many things going into the pandemic, and we've talked about this year before, we had data that fundamentally demonstrated that minority patients were significantly less likely to be on our patient portal for a whole variety of reasons that we'll get to in a moment. So that was kind of a first strike in their ability to be connected with us. So I was left primarily with, telehealth as a vehicle. We used Doximity for a little bit, then we moved to Zoom, integrated into Epic, and it was a very steep learning curve for us. And I think we felt very limited in what we could do, particularly for people like me who could just really just check in with people, almost do safety checks with people. But for my individuals with diabetes, my individuals with high blood pressure, I couldn't get the data I needed. The kind of pinnacle of virtual health is literally having connected devices where you can get a reading in your home. We can get some data either in different mechanisms, health hubs and the like. So that was all very limited, and I think it was challenging. And I'm happy to go into kind of some of the reasons um, why virtual healthcare is particularly difficult for vulnerable populations as well.
Well, I know how much you care about your patients. So how was that for you? How did it feel to have that set of challenges in front of you as you're trying to care for people, particularly people with chronic health diseases?
Yeah, it was challenging. I mean, it was challenging because, you develop a cadence with your patients of seeing them every 4 months, getting data that you need, trying to manage them closely, making sure that they're getting their prevention, and wellness activities and measures and testing done. So it'd be colonoscopy, mammogram, pap smears, eye exams, all those things. And you really were limited. So you were, and I was just trying to stem the tide, really prevent serious things from getting too difficult, and really trying to also triage patients who I knew were sicker to make sure I was connecting with them. And the reasons why I think the connectivity around virtual health became challenging were ones that we've talked about. The digital divide still persists for many. A laptop at home is not kind of standard. Clearly, if you do have a smartphone, you may have limited data options, which prevent you from being able to connect on a Zoom or through Doximity because of the cost of that access. Some communities still have difficulty around broadband access. And I think the tech literacy, I had a lot of patients who were very health literate, and I'd say even among those, maybe 40% couldn't figure out how to connect on Zoom with me, right? So, there are a series of barriers here that emerged that I think became very challenging for people, and ones that I think, tried to think about, but there weren't easy solutions. You need to think about, okay, can we do advocacy with the tech companies to expand broadband? Can we think about getting devices to people? We were able to do some of that through some donated devices that were hot linked to the web and to cellular data. How can we onboard people? So if I give you a device, what am I going to need to do to onboard you? How are some of our specialists, when they want to do these visits, how are we going to patch in an interpreter? They need an interpreter. These were all things that we needed to think about very, very quickly. I'd like to say we put in some basic seeds, and we have some roots, and maybe have some seedlings growing up in the ground. But like many, many things that we experienced with the pandemic, this again shined a very bright light on kind of these big gaps that we have learned to live with and learn to accept. And so these disparities were built in without a doubt. And I think that in a go forward basis, as we really want to maximize our capacity to do virtual health, we need to, as we've talked about here, think about equity in all efforts and really run through these series of barriers and figure out how we can begin to address them.
Indeed. Indeed. So can you talk a little bit more about what you think? It feels like um, virtual healthcare is here to stay, born in an emergency, but now here to stay. What do you say is the promise for making that more equitable and culturally competent? You've talked about some things like interpreter services and how to engage, but I wonder if there are other elements that you think should be considered within this.
Yeah, it's a great point. I mean, there's no doubt that virtual health is here to stay. And what's interesting is even early on, some of the payer policies around this, right? There was initially, and there had to be advocacy. Initially, there was a differential payment, virtual, like you and I are seeing each other versus telephonic. And we had to do a lot of advocacy at the state and federal level to say you can't treat those differently because you're fundamentally disadvantaging and disincentivizing the care of individuals who don't have access to technology. And so that got reconciled. We hope that's reconciled for the long haul. It's exciting in some ways because now that we've gotten a little bit better at it, my ability to check in with patients more easily, more quickly on things exists. I think if we can get to what I envision is some more technology that allows me to get blood pressure data or some other data. If we have health hubs in communities where people could go get some labs and I could see them, where they could get their blood pressure checked. So as I think about this, I think virtual health is here to stay. I think that there is a benefit to virtual health given people's busy schedules, and particularly for vulnerable populations who may work two jobs, who getting to see me would require taking time off and is very difficult. But a 15-minute Zoom call could be incredibly helpful to check in. And but we need to create this biosphere of equity around virtual health if we are like anything, to maximize its potential. And we understand clearly that our story nationally around the diffusion of technologies and therapeutics to vulnerable populations always is delayed. And so this again is both an opportunity but a big risk. We cannot leave people behind as we push towards virtual health. And I think one thing that we've talked about, and let me give you almost a great case example of how this works and how it might work, particularly around disparities of vulnerable populations. We understand that people are more stressed now than ever before. Depression and mental health issues are disproportionately impacting vulnerable populations. We've talked about it here. And I think those populations have particularly faced three challenges as it relates to getting good mental health care. Number one, stigma. This idea that from a culturally competent standpoint, how you talk about depression really requires a lot of skill because of the great stigma, and stigma was often a barrier to people pursuing mental health care. Number two, the physical kind of social determinant of transportation, getting somewhere to do it once you were motivated to do it for individuals who were busy or challenged became the second barrier, and again among the more vulnerable. And number three, if you got past the stigma and you got to see somebody, more often than not, if you're a person of color, you're not sitting across from a person of color who's your therapist or your mental health care provider because of the numbers, because minorities are underrepresented in the healthcare workforce in general, and certainly among the mental health care workforce. So you are facing these three major barriers. So what does the promise of virtual health bring to mental health care? Well, first, as it relates to stigma, with appropriate virtual health, you could sit in your bedroom and nobody has to know in the privacy and confidentiality of your home, and you can engage with the mental health provider. Stigma check. Number two, if it's difficult to get somewhere, virtual again allows you to do it without needing to take much time. Social determinants of transportation check. And number three, in a well-constructed model, you don't need to see a mental health provider, in Boston if you live in Boston. If the model is set up so that we're able to maximize diversity among mental health care providers and have a national network, then you could sit in Boston, and maybe you could see a therapist in Washington, D.C., or somebody in Atlanta who's a person of color who looks like you, who you feel more comfortable with. This is the promise of virtual health. As it relates to chronic disease, the promise of virtual health is our ability to monitor people much more closely in a way that's less disruptive to them. But the caveat is we have to address technology, and we need to have the technology as well to get some data, because I could see you once a week if you have diabetes, but if I don't have the data I need, it becomes difficult to manage you. So with that virtual care, I think that becomes incredibly important. And I'd end by saying that cultural competence is critical, as always, to these sets of efforts. It becomes the entree by which we begin to think about equity in virtual healthcare. It becomes that skill set and tool set that we use virtually to, again, do the things we've talked about, get out of patients, for example, in the case of mental health, get out their understanding of why they're feeling down and blue or stressed, right? With thoughtful questions around the explanatory model that doesn't stigmatize or use words like depression that people link to crazy, that you can, in a thoughtful way, and using the model of mental health, use the explanatory model questions that are able to ascertain an individual's kind of mental health and status. You are able to get a better understanding of the social context. What we talk about a lot, Michele, that's been really interesting is, home visits and house calls used to be, I think, were seen as a thing of the past, and there was a privileged few who were getting them, and visiting nurses, do them a lot. And what they say is an incredible benefit to doing house calls, what you're able to see in the environment, right? How you're able to take the camera and do this,
Yeah.
and because you get to see you see a fall risk, you see, the kind of social context. So we've talked about social context so much, and now I may have a window into your home. I might tell you can you walk me through your home so I can identify certain things that might pose risk. I can, have you give me a look into your cupboard, right, and see what kind of food you have. So the potential there to be more connected to someone, I think, is incredibly important. And that really kind of sits on the social context that we've talked about so much. And the interpreter piece is critical. So virtual health, now we're able to dock in interpreters into our virtual health visits in ways that I think are important.
That was such a powerful answer, Joe, thinking about how you can manage medical adherence, how you can think about nutrition, family engagement through virtual healthcare. I'm wondering if it's difficult or challenging to build rapport virtually. What is different in the context of cultural competency when you are meeting with somebody really in their home? They're somewhat exposed, right? And how to work through those kinds of issues.
Yeah, it's I think we have the benefit, Michelle, that we, as quality actors have worked with health plans for a long time, for whom their connection to the member is telephonic, and we have tried to I think highlight how the deployment of these cross-cultural skills in a virtual way, telephonic, not even looking face to face, can be used to build rapport. How tone of voice, sense of connectedness, care, empathy, and compassion can be conveyed in a virtual way. And that was telephonic. That wasn't even kind of virtual, being able to look each other eye to eye. So I do believe that there are a set of skills that absolutely allow you to build trust virtually. I might argue in some ways, people have said even more so, because people may have a little bit more time, both the the patient and or member. Um, you might be able to invest, given that I'm able to connect with you virtually, maybe at a higher cadence than when we see each other regularly, to build more rapport out, and to do that virtually. I think, as you mentioned, kind of getting a view into someone's home, into someone's life. Social isolation is the single biggest predictor of kind of depression and hospital readmissions. Virtual health even becomes an intervention in so much as not only you building rapport, but you're giving somebody, someone to connect to. And again, I think that could be telephonic and virtual. I think virtual even magnifies that, because you're able to look an individual, in the eye, be able to smile at them, be able to engage with them in ways that, may have been difficult at a more routine cadence, as I mentioned, than kind of checking in with somebody less routinely. So I think that building rapport piece, now I'm actually connecting with patients more routinely, and even deepening our relationship, because it's easy to do. By that I mean I could fit you in for a 10-minute virtual check-in, and that's so less disruptive to you. And from my standpoint, I'm able to execute a note more quickly. Everything I do is quicker, staff time. So we really need to push the boundaries here, but we really need to make sure that we are doing this in an equitable way, in a culturally competent way, and are not leaving people behind. I think that's the real lesson. So your point around virtual health is here to stay. It is. And the message to innovators, to those disruptors who really want to think about equity, is to think about equity, to think about some of the things I've mentioned, and there's probably more that I haven't mentioned. This will be a learning process, but that discernment, like we've said all along, is going to be so important for everything we do. And this pandemic has taught us that we have, accepted these big gaps, and that real innovation happens when we are detail oriented and we think about the kind of challenges that I mentioned, and they're not unique to minority populations of all communities.
Right. Some of the lessons we're learning about COVID is the commonality, right, of deprivation or the lack of resources, and how it shows up in deadly ways for all communities.
Yeah, without a doubt.
So we're about to land into the head into the holiday season, and I would be remiss if I didn't ask you directly if there are two or three things that you think everyone on this line should be promoting to stay safe and healthy through the holidays.
Yeah, it's hard, Michelle. And I think to tell people to, we're working on messages right now for our hotspot communities on the holidays. And what I've made clear is that people are tired of the same old message. And to tell people, it's like it's like the cross-cultural negotiation skills that we teach, right? We talk a lot about cross-cultural negotiation. In fact, that if we just tell people don't celebrate the holidays with family, just like we, have taught, we really want people to use interpreters, but some people want to use family members. We understand that, okay, what are some guidelines we could give to, to make these less than optimal situations that are going to occur more optimal? To act like they're not going to occur and to kind of use this dichotomous approach of yes, no, really misses an opportunity for us to kind of leverage what is likely going to happen, is that people are going to want to engage and they're going to engage. So the advice needs to be, if you are, want to see your family and you want to spend time, think about a couple things. First, doing it outside, and I know weather makes that challenging, but even if briefly, decreases risk. This is going to be all advice around, risk mitigation. If you're doing it outside, even if it's a brief gathering, not in big numbers and social distance with masks, is safer. So if you want to get 5, 7, 10 family members together and you can socially distance in a backyard and you got a couple of heaters, or even if you just do it for half an hour, I think that's fine. I think that's probably the safest thing to do. Then if you're going to do something indoors, you definitely want to do masks. You definitely want to leave windows open, right? You want to make sure it's well ventilated. And ultimately, you really, really want to protect vulnerable members of your family. So you want them masked up and maybe you want them well across the room, but increasing ventilation, increasing social distance, and wearing masks indoors is going to be important. And I think those are what we're trying to, some of the key messages we're trying to say. So if you're going to do it, you're going to do it indoors, open the windows, put those more vulnerable, far apart. And please, I think the biggest risk in the clusters we've seen in the healthcare space have been around people eating in close quarters. So don't, we know holidays are about breaking bread with loved ones. If you're going to do it, spread out big time, but please, and open those windows, let ventilation exist, but please, that is the biggest risk of spread. If you all are going to sit around a table, and even if you put a little distance between you and you're not going to wear masks, you'll be eating, research has shown that that's where we see spread happen. So those are kind of the things that we're thinking. There'll be more to come here, Michelle, but those are some of the preliminary thoughts that I'd share with you.
Well, that's very helpful. And I think that's a wonderful way for us to conclude this conversation with that great advice as we plan. Joe, thank you again for sharing your wisdom and your time with us. Do you have any last words?
No, it's my pleasure. We look forward to, I think we have a couple more conversations coming up, particularly around some other pressing issues that are emerging. And, we just got to stay with it. I will say that we are doing better around some of the therapeutics and now having better knowledge on how to care for people when they come in. The vaccine development is happening. So there is a light at the end of the tunnel here. So we just got to get people to get through this challenging cold weather holiday season and stay safe. So that would be my parting thought for today.
Exactly. Staying with the program and being resilient in the process.
Yeah, exactly right.
Well, thank you so much for joining us today. We look forward to you coming to our next live discussion later this month. You'll get more information about that shortly. Have a good day.
Great. Thank you, everyone.